come up with solutions that are sustainable in each of the countries. At the end of the day, we're hoping to create a network of experts where there will be opportunity for future collaboration and learning opportunities. Next slide, please. So I'll hand over to Julie just to help us ensure that we're able to identify who is speaking part time. Julie, do you want to take this off?
Yes, thank you. Many of us are joining either by our phones or computers, and so our names can get either named by our computer or otherwise. And just to ensure that we're able to have that peer collaboration, if you would take the time now to just change your Zoom name. So if you go on to your little box where your name is presented, if you go to the top right corner, you'll see a blue mute button. And then next to that, there's another square box with 3 dots in it. And so if you hover over that or click on it, it'll give you the opportunity to rename. And so then you'll click on rename. And once you click on that, if you can, write your first name and then the full name of the safe blood system that you belong to. If you want to just write MBTS or BTT or MBSP, you're more than welcome to do that. We are familiar with everyone here, but for those of us that are not, it might be helpful to just write the country that you're from and then potentially the blood service. So again, if you just go to the box where your name is and you go to the top right corner, there's 3 little dots in that square. And then if you hover over that, it'll give you the opportunity to rename yourself. So you'll just click on rename, type your first name or your surname, and then the national blood service that you are a member of.
Thank you so much, Julie, for that. So while we are doing that, to ensure we even have an idea of those on this call, it will be nice for the team leads to just quickly tell us about the team members that are on the call. I know we should have teams from Liberia, Malawi, and Rwanda on the call. So I'll just call on the team leads. Not in any particular order. Just tell us, introduce yourself, and just tell us your team members available, so we don't have to go from one person to the other. Just tell us, oh, the people you have with you on the call. Remember to mute yourself if you're not speaking to make sure we reduce the distractions. Thank you so much. So first, not in any particular order, I will take the Malawi team. So, Natasha, do you want to introduce your team members to everybody on the call? I'm sorry, is Natasha on the call?
Mrs. Turwa, would you like to introduce the participants from MBTS?
Good morning.
Good morning.
Yes, I'm Mavis from Malawi. With my colleague Janet. So we are the 2 of us from Malawi.
All right. Thank you so much and welcome to this call. We'll move over quickly to Liberia. Dr. Suba, do you want to introduce yourself and your team members on the call?
Good morning. This is Dr. Suba, the Program Director for the National Safety Program of Liberia. In the Region 1 Blood Center, and I'm with the Field Coordinator, Mr. Moba Kekula, the Program's Deputy Director, Mrs. Soile Lomax Ireland, the Region 1 Blood Bank Manager, Mr. Pierre Joe, and his deputy, Mrs. Ruth B. Dennis, yes. So we are here, and Region 2 is also online, but they will make their introductions from their end.
All right, that's fine. So can someone speak up from Region 2?
Yes, okay. Good morning to all. This is
Good
Moses
morning.
Dewey. Yeah, this is Moses Dewey from Region 2, the blood bank manager. And here I am here with the blood donor recruiter, Mrs. Lomeni Formasona, and also with the nurse counselor, Kepe Piwi, Kepe G Piwi, the data client, Catherine Shejus, and then the phlebotomy, Mr. Bang, MV Kun, and Daniel Quena, also one of our staff.
All right. Thank you so much, Liberia
Our
team.
money is on her way, already coming.
All right, all right. Thank you so much, Liberia team. We're so happy to have the full team here, and we hope to have an engaging session with you. Lastly, I'll move on to the Rwanda team. Is Dr. Gasheja. Apologies if I've murdered the name. Is he on the call, or is anybody representing him from the Rwanda team? All right, so I'm sure they'll be joining us in a few moments. That's fine.
Hello, hello.
All right, please go ahead. We can hear
Yeah,
you.
I'm Doctor. Yeah, I am Dr. Theophile Sengumremi. Even if I'm not working with Rwanda Blood Transfusion Division, but at least I'm a local consultant working with Results for Development. So I'll be following up, let's say, on behalf of Rwanda. Yeah.
All right. Thank you so much. And I think I like that energy. At least we can say Rwanda is represented. Thank you so much for this.
Yes.
Hello,
Yeah.
hello, can I
Yes,
just
please.
come in?
Yes, please
We've
go ahead.
we've got more joining from Malawi.
All
We've
right.
got we've got
Please let's
Chawanangwa.
know others.
Yes, we've got Chawanangwa, who is the accountant manager, the finance manager, and Mr. Smwela, who is the chief lab officer, and Mrs. Upile Kaimbi, the public relations officer.
All
Thank you.
right. Thank you so much. Thank you so much. So we'll move on to the welcome remarks. I don't know, is Adele on the call? Is it going to take this now?
It doesn't appear that he's on the call, but for those that aren't familiar with the Strengthening Safe Blood Systems, the HSS Accelerator is a USAID funded project, and it's implementing interventions to increase access to safe blood in Liberia, Malawi, and Rwanda. And addressing the issue of postpartum hemorrhage, which remains a leading cause of maternal mortality worldwide. And while there's been significant progress with skilled birth attendants and the availability of other interventions and prevention for the management of PPH, timely access to blood transfusion as an essential component of emergency obstetric care still remains a challenge. And so the objective of this project from January 2022 to next year in June, in close collaboration with the AID missions in all three countries, is to co-facilitate the application of that Safe Blood Starter Kit assessment, which has been concluded in all three countries. And using that Safe Blood Starter Kit assessment, we were able to identify some primary challenges to the availability of safe blood for the treatment of PPH, as well as to prioritize opportunities and potential solutions to those challenges. So we were able to co-create and are currently implementing interventions with the national governments in all three countries to provide that targeted technical assistance to the identified challenges from the Safe Blood Starter Kit assessments. The next objective is to organize and facilitate these cross-country learnings, and where possible to produce global resources on strengthening health systems for safe blood to expand learning and impact beyond the three countries. Over.
Thank you so much, Julie, for that reminder of why we're here. So we'll just dwell a little on specifically the cross-country learning events. Yes, just like Julie has said, we felt that there was a need to ensure that there are opportunities for these three countries to collaboratively learn together, and that's really what the cross-country learning activity is about. It's to provide an opportunity for organize and facilitate cross-country learning across the three countries and the stakeholders to exchange knowledge, solutions, and best practices, as well as to learn from what is currently ongoing in these three countries. We understand that if we can work with these three countries, then we can as well come up with solutions that can be scaled up across the sub-Saharan Africa. For this cross-country learning activity, it started in May 2023 and it will be running till June 2024. This bit of the work is being done in collaboration with HSDF, that's the Health Strategy and Delivery Foundation. And for us, what we ought to achieve by June 2024 is to strive to assist blood systems change agents um, and to learn from and replicate generative information for timely decision making. I think it isn't enough for this information to be made available. It is important for it to be used for decision making and also to come up with evidence building to enhance peer-to-peer learning. We're also open to lead country and demand driven joint learning methods. So if you understand, I think sometime earlier this year, we interviewed different stakeholders across the country to understand what was the burning concern, and it was based on that this webinar is happening. This is something that we think we really want to learn together, and that's why we're having this webinar and subsequent webinar to ensure we're able to learn on how to improve our system. So the cross-country learning is supposed to act as a complementary to the technical support that has been provided in each of these countries and to exchange support when it comes to leadership and decision-making meditation, and also analysis and the use of how we can better use our local experts to drive a system change. And lastly, we're looking at for joint learning to accelerate progress and strength to host countries safe blood implementation and also facilitate experience sharing and problem solving. Yeah, so this is in a nutshell is what we're hoping to get out of the cross country learning activity. So a little icebreaker before we move ahead. I'll just hand over to my colleague Adora to take us through the session. Adora.
Thank you, Sumbo. Good morning / afternoon, everyone. Welcome to this learning session. We have a lot of information coming up, but before that, we just want to get started with a quick and fun icebreaker. So there are three ways of joining. You can either scan the QR code on the screen or go to the website that you see below and enter the code. And then I will also put the link in the chat box right now. I will give everybody about 45 seconds to join, and then we can get started. As you can see from my screen, there's a simple prompt. It's just let us know, depending on your mood today, what type of fruit or vegetable you feel like. We're hoping everyone is in a great mood, so hopefully summer fruits, oranges, kiwis, and things of that nature. We're already getting responses in. Someone feels like a pineapple. Watermelon, that's a good fruit. Yeah, these are all really great fruits. I will let a couple more people. Ooh, papaya, it's a good one. Please let us know in the chat if you're having difficulty joining, and we can troubleshoot on our end. I'll wait for a couple more responses before moving on to the next question. But these are great so far. Thank you. Great, thank you. I will move to the next question so that we have enough time, but keep your responses coming. Thank you so much. So for this one, just in a few words, please let us know what you're hoping to learn from the session today. It could be anything big or small. I'll wait for a couple more, and then we can always come back to these later. Amazing. These are really, really good ones. I love that a lot of these involve strategies. Yes, that seems to be the key word here. Thank you so much for participating in this. These will be up, so you can always go back and see. But I will stop sharing now so we can move forward with the webinar. Thank you so much.
Thank you so much, Adora, for that. I hope that was a little what's it called? Waking up session. Something fun and something still serious. All right. So now we're going to meet our speakers. Next slide, please. Um, like I said, the Malawi team will be sharing a case study with us. Next slide, please. Okay. Yes, please. Thank you. So we have 3 speakers today. From the Malawi team, we have 2 speakers. So we have Mrs. Malvis Chawa, pardon me. She works with the Malawi blood transfusion team. She's a management nursing professional with over 18 years experience and specifically 8 years as a blood donor manager. So we know she's coming in with a world of experience. We also have Mrs. Janet Katonda, also from Malawi. She is a passionate associate, chartered marketer with over 7 years of experience. She's working as a marketing and public relations manager also within the Malawi blood transfusion services. She's currently pursuing a master's to further improve on our skills. And then for our guest speaker today, we have Mr. Manad Muten Awa. Again, apologies if I murdered the name. He's from the Zimbabwe National Blood Services. He has agreed to provide a little more details about what is the best practices when it comes to donor mobilization and retention. He joined the service in 1998 and was first the principal medical laboratory scientist heading the transmission transmissible infection unit. He currently serves as a blood supply executive and is a member of the African Society for Blood Transfusion and International Society for Blood Transfusion. Thank you so much, our 3 guest speakers, for agreeing to facilitate these sessions for us. We'll start off with the case study from Malawi, and so I will hand over to the Malawi team to um, do justice to this. I'm not sure who's kickstarting this, but please, Malawi team, over to you.
Good afternoon. I will
Good
straight
afternoon.
away go into the presentation. So the presentation is going to cover the following topics. We are going to talk about the background, a brief background will be given. We are also going to discuss the challenges encountered, the lessons learned, the key success factors, recommendations, and at the very end, we are going to have time for questions and comments. Over. So a brief background on the Malawi Blood Transfusion Service. This is a trust which was established in 2003 by the government of Malawi through the Ministry of Health. MBTS is mandated to collect and supply adequate and safe blood and blood products in all the hospitals in Malawi. Of course, those hospitals which have been certified, it's not all the hospitals, but only those who have been certified by the Ministry of Health, of course, after complying to certain standards. MPTS also collects blood from voluntary and remunerated blood donors, of which 75 to 76% of these donors are students. The students range in the ranges of 16 to 25 years. MBTS plans blood drives in schools every 4 months, and this is the period where one is required to donate the difference in between. MBTS prefers to collect blood from students because they are regarded as low-risk behavior donors. However, when schools are not in session, MBTS conducts open days clinics, which are conducted in busy trading centers and in communities wherever there are people. So MBTS has identified 3 best practices for donor recruitment and mobilization. So as you can see from the diagram, there are static clinics. These are clinics where donors would just walk in and donate blood. Then the other strategy is school approach, sometimes called district campaigns and bus drives. And the third strategy is open days. So Malawi Blood Transfusion Service approaches recruiting and mobilization blood donors in 3 primary ways, as I have already explained. Over. So this is an overview of the static clinics. MBTS has 4 static clinics situated in its district offices in Lilongwe, Balaka, Mzuzu, and Blantyre. So these are the cities where our blood centers are located. The static clinics accommodate walk-in voluntary blood donors, and the static clinics consists of 1 donor team. So on a daily basis, there is a donor team operating at the static clinic. And the clinics operate from Monday to Fridays, and sometimes during weekends and public holidays, and whenever there is demand. Even at night, when there is a demand, a team would be called to conduct blood donation if a donor is available. On average, an average of 25 donors visit and donate blood at the static clinic every day. The clinic contributes an average of 19% of total blood collections. This is based on the data which was generated in the last financial year. Over. While static clinics provide a cost-effective means of donating blood, long waiting times and limited accessibility may deter potential blood donors. So we are going to look at the advantages and disadvantages of conducting these static clinics. One, it's cost-effective because the donors just walk in. There are no costs associated with this type of strategy. The other advantage is that it is accessible and allows voluntary donors to donate blood at their convenient time. And donors sometimes would book to come and donate at their most convenient time. Sometimes the donors book after working hours. So the members of staff would remain to wait for that donor if the donor has booked. It is more efficient. Processes may reduce waiting time. There is good donor interaction. The disadvantages are operating hours do not align with other donor schedules. For example, where donors would book when the teams are supposed to knock off. So the other disadvantage is that limited accessibility only targets donors who stay close to the clinic. Depending on centers' efficiency and number of donors may experience long waiting times, especially on busy days. Limited community engagement and deferred donors may be demoralized after being retained back, because after spending money for coming to donate blood and then they are deferred, most of the donors get demoralized when they are sent back if they are deferred due to conditions which does not necessitate them to donate blood. Over. So MBTS uses 2 school-based approaches. The first approach is district campaigns. So bus drives are conducted in schools with MBTS team physically on the site to collect blood. The process involves identifying an anchor school to conduct blood drives and attracting students from other nearby schools. 2 teams in 1 district conduct 2 to 3 clinics every day. An average of 30 pints of blood is collected per clinic during these clinics. Motivation talks are given prior to actual blood collection. So as you can see, we've got vans, we've got vehicles which would enable us to travel to clinics and be there physically to collect blood. Over. So during bus drives, MBTS picks students from various schools to donate blood at a static clinic. This is another approach where we collect students from various schools around the static centers and we mobilize them and they donate blood at one central point. So as you can see from the diagrams, this is one of our static centers in Baraka where the students were donating blood, and the other picture is showing the donors filling in the donor questionnaire form at a static clinic at one of our centers in Blantyre. Over. So we've got a process which we follow when conducting these bus drives. Firstly, MBTS conducts awareness talks. So these talks are conducted either on television, we use TV, social medias, and our public relations team goes there and conduct motivation talks. And once we agree with the school teachers or the head teacher, they will give us a date where we'll go and conduct the clinics. And in this case, if it's a bus drive, then we'll mobilize our vehicles, we'll go and collect the students at a central point where they would donate blood. So MBTS conducts physical examinations, counseling, then blood collection, and students are dropped off at school after donation. Over. So these school bus drives have shown that they provide a low-risk, high-yield population of blood donors. However, gaps in donation can occur during holidays and in rainy seasons. So from the data that we have, we've had high yields from such bus drives, but the challenges come in when the schools are off seasons. So we have got some advantages here: the low TTI rate, easy to mobilize donors for blood donation and motivation. There are high-yielding clinics, and students encourage their peers to donate, especially if this is conducted as a cluster, a good ground for creating a pool of potential blood donors for the future. The disadvantages of this approach is that there are low blood collection during during school holidays when the schools are not in session. And the challenges sometimes may come in during rain seasons when the roads are impassable. Some students may not be eligible to donate blood due to age, weight, or health conditions in some schools. Some students may still require to get consent from their parents because our threshold age for blood collection is 16 years. So you see that most of the students, they will still want to ask their parents for consent before they donate. So yeah, that is one of the challenges. Over. So apart from bus drives, we also conduct blood donation open days clinics. In this approach, MBTS goes to the community to collect blood, like trading centers and busy places where there are a number of people. This approach is used during the lean period when the schools have closed. In the 2022-2023 financial year, open days contributed 16% of blood of the total targets set by Malawi Blood Transfusion Service. Over. So as you can see from this diagram, between April and August 2023, open days yielded over 6,000 more donors than in the next best strategy identified. So you can see that this was during the time when the schools were not in session. We targeted the busy clinics, and our intention was to follow up the donors in the communities while they were on holiday. And then we also targeted the community, the people in the community. So you can see from the graph here that from the open days, we collected a substantial amount of blood during this period. Over. Yeah. Open days have proven to be high yielding, though costly. and the cost mostly is incurred during mobilization, as a lot of mobilization has to be done. So though being high yielding, it's costly, and high rate of TTIs were identified in these open day clinics. Over. So this is a summary of the blood collections in the period 2020 to 2023. The district campaigns symbolizes the bus drives yielded about 55% of the total collections, followed by the open days, which is represented by 16%. Over. So the key success factors for the school blood drive approach is that it provides the ability to collect adequate and safe blood, cooperation between school teachers and patrons at the school, because before we go to conduct the blood school, there is a lot of interactions between the teachers and the blood transfusion team. So it has also had availability of resources, conduct the bus drives to ensure quality, and the attitude and motivation of MPTS staff workers. So because of these bus drives that we conducted, we were able to collect more blood. And this motivated the staff workers, because we had a meritorious award, because for the first time in the history of Malawi Blood Transfusion Service, we have reached, we have managed to hit 110%, 110 pints whole blood were collected during the last financial year. So this is a very big achievement in the history of Malawi Blood Transfusion Service. Over. Over. So the Malawi blood transfusion process and concepts are taught in schools. This is also the lessons that we have learned from these drives. The syllabus, blood donation was also incorporated in the syllabus. So this has also provided us with an opportunity to make our motivation talks and motivating the students in blood donation easy, because they have already learned it in class, because it was included in the school syllabus. Yeah. And the other lesson learned is that MPTS has a feedback mechanism which is well coordinated by the IT department. So the IT department was purposefully put in place to monitor the feedback from the donors, because he's an independent, he doesn't interact with the donors. So all the comments, the feedback from the suggestion boxes are analyzed by the IT department, and then he directs them to the responsible people who are supposed to review them. So the feedback responses are collected and sent to the IT department, and adaptive management. This has offered a conducive environment for adaptive management. So for sustained donor retention, milestones awards are used as motivations. Over. So this is an outline of the milestone awards that we give. When a donor comes to donate for the first time, we give them a sticker where it is written, "Be nice to me, I give blood." And to the, for the students, this is not this is something which they are proud of. When you put a sticker on their uniform or shirts, it's something to motivate them. And then we also give them a wristband where it is written, "I donate blood." When the donors come for the second time, we give them an ABO card and a pen. And the ABO card is a card where the blood group of that donor is indicated. On third time donation, the donors are given a t-shirt, and it is written there, "Does or someone, I'm a third-time blood donor," and it's such a proud for the donors to have this t-shirt and just to walk around with it in their community. On the fifth donation, we give them caps and t-shirts, And then we give them a drinking bottle on the 7th donation, and the milestone awards goes down until on the 50th donation, when we give them medals or a trophy, depending on what is available at that time. Over. So we also encounter challenges as we are carrying out these initiatives. Some schools are in rural areas and hard to reach places. This means that the teams have to camp in the district for a week for easy mobility. This also requires additional allowances for the team. So in case where we've got financial constraints, this becomes a barrier. There is shortage of blood when schools are closed for holidays. This used to be a very critical problem in the past when the open days were not yet introduced. So when the schools are not in session, the blood stocks are low. But we have put in a remedy in that we are conducting open days where we are following the donors in their communities. Yields from universities are not as high as compared to secondary schools. Average age of graduation from secondary school is 16, and this is the threshold age of consent for donation. Okay, let me come back. So what we have also observed is that students nowadays, they graduate from secondary school at a very tender age, especially those in private secondary schools. So by the time they reach the age of donating blood, which is 16, most of them, they are already out of school. That's why this time around we are also working on strengthening the community clinics, where I would still follow up the donors in the community when they graduate from schools, and also working hard to still motivate the blood donors who have graduated to colleges. The other challenges that I encountered are some donors stop donating blood once they graduate. I've already explained about this. Over. The next slide, please. So recommendations on the status of blood system for mobilization and retention ensure that all SOPs are drafted and circulated. So if one wants to engage in these blood drives, make sure that the SOPs are drafted, they've been secured, they've been certified, and that all the staff members are well trained and certified according to the standard operating procedures. You know, working with students may be a challenge. It needs people who are well trained both in customer care skills and how to handle these students. Proper feedback mechanism in place has to be in place, and which has to be reviewed on monthly basis. Like the way we've done it, we've given the responsibility to evaluate the customer complaints and the compliments to an independent person who doesn't directly work with the donors to evaluate, and that feedback is given on monthly basis. School drives may be conducted 3 times a year at each school. In our case, we conduct these bus drives 3 times or 4 times a year, because we want to give the female donors a chance of waiting for 4 months, because what we do here is that we allow our female donors to donate after 4 months and male donors to donate after 3 months. So usually we go to these clinics after 4 months so that we should capture all donors, both male and females. Then plan activities in line with school calendar, for example, examinations, school breaks, etc. What we have done is that we work hand in hand with the Ministry of Health. We formulate our planner in line with the school calendars. we avoid days where students are writing examinations, because we don't want to collect blood from students who are writing examinations, because we don't want to disturb them in any way. So our programs are aligned in such a way that when the schools are in session, that's when we arrange for these blood school bus drives. And when the schools are not in session, we plan for the open days. And this has really worked. So one other thing that we should consider when planning these bus drives is to consider road networks. Like in our setting, like last rainy season, we had the Cyclone Fred, Cyclone Annie, which affected most of our roads, and some roads were impassable. So the lesson that we learned from this scenario was that during as we are approaching rain season, we make sure that we go to areas where the roads will not be passable when the rain season sets in. Over. Yeah. So thank you. This is the end of the presentation. Thank you.
Thank you so much. I think that was very, very enlightening. It was nice to see an innovative approach that is still context specific to ensure we're able to drive blood mobilization and donation. And I think for me, the greatest spill for me here will be the feedback mechanism. I think a lot of times we are in the habit of just receiving, but never hearing back from the end users. And I think, and the fact that you thought this through and ensure that is a system that is devoid of any form of influences, I think that's really commendable. Thank you so much to the Malawi team. That was really beautiful. I know there are questions. I know there are a lot of questions. You could use the raise hand button, or you could quickly type in your questions in the chat box. We have like 3 minutes for the Q&A session, so it has to be really fast. Priska, please, can you mute yourself? We need this to be really, really fast, so that we'll have enough time for the guest speaker. We're already running a little behind schedule. Region One, I can see your hand is up. Do you want to go ahead? Please unmute yourself and ask your question. The Liberia team, Region 1, do you want to go ahead? We can see your hand up.
Yeah, hello.
Yes, I can hear you. Please go ahead.
I'm Moba Kekula, the field coordinator of the National Blood Program in Liberia. During your explanation and your explanation and what was on the board, I saw open drive, and I want to know who are those that are targeted during the open drive. Hello?
Yes, thank you so much.
Hello?
We got that. Do you want to answer? It
Do
says who
you
are
mean,
the targets? Yeah, please go ahead.
do you mean open days or bus drives? Because there's an open day and then there's bus drives.
Okay. Okay now.
Open day.
Okay. So basically the open day targets the community at large and also the students who are our primary target. So these ones take place during holidays, where MPTS goes down to the communities and conduct these open days in training centers, so that we target the people that are in the village and also the students that are on holiday. So these open days only take place during holidays. Thank you.
Thank you so much. So it's still the students, but you get the opportunity to still reach out to them during their holidays. Thank you so much for that. And do you have any other questions?
Yeah,
Region 1, do you have another question?
Yeah, I have a question on the age level. According to the international standard, every blood donor is supposed to be the age of 18. Oh, I didn't introduce myself. I'm Sole Lomas Arlen. Thank you for your narration. So my question has to do with the age level, because according to international standard, every blood donor is supposed to give blood at the age of 18. So can you just tell me why you are collecting blood at the age of 16?
On the,
Yeah.
okay, let me come in. On the age level, yes, as much as international standards, it's 18 years. We had to go through various processes to get this, to be allowed to go to 16 because of some other issues which may not be discussed, of course, here on the forum, but we had to undergo several consultations to come up to the age of 16. Thank you.
So some levels of approvals needed to be gotten for you to lower what's it called, a waiver more or less for you to
Yes,
lower
yes.
the age. Yeah.
Yes,
Thank
yes,
you
yes,
so
yes.
much. Do we have any
Yes.
other question?
I saw the questions.
Yes, Kimberly, please, do you want to do justice to that? Please go ahead.
Okay, so in the chat, we have two questions. First is, does the Malawi do 100% voluntary, non-remunerated blood collections? And secondly, how do you get parental consent when you invite students to donate blood at static clinics? This is from Zimbabwe.
Okay, Malawi, we advocate for 100% voluntary and remunerative blood donation. But in some other areas where maybe due to other challenges, where maybe the health facilities may not have transport to come and collect blood at our centers, they would do some family replacement. But from the statistics that we have done, when most of the central hospitals, family replacement has stopped. And all this has come up because of the numbers of the numbers of blood pints that we are collecting. But I may say it's 100% non-remunerated blood donation, that is voluntary donation, and a few family replacement here and there. And the other question was how we get consent for the donors to donate blood. We've got a donor questionnaire where the donor has to fill in before he donates blood. And in that questionnaire, we have incorporated an area where the donor is supposed to give consent. So every donor who donates blood gives consent before donation. Thank you.
Thank you so much. Just in case I missed it, I just have one question. So in total, what percentage of the available blood in Malawi is gotten from the school drive initiative?
May you please come back?
So I said in total, what percentage of the available blood in Malawi is gotten from the blood drive, from the school blood drive?
Okay, like taking advantage on the statistics that we had last year, so we just refer to that one. So at least last year we got about 55% out of the total target that we had. So it was that's what we currently have now. That's kind of what we got last year.
All right, that's good. So it means the school drive plays a very, very important role in the total blood available in the country. Great work, great work. Thank you so much to the Malawi team. Thank you so much. And thank you so much for everybody for listening. Because from the questions I can see that we all found that presentation very interesting. And quickly, right now, we'll move on to our guest speaker that's speaking to strategies for recruitment and mobilization of donors within the LMIC, and we'll cover the need for culturally sensitive information to counter misconceptions, which you know is a problem, and to also look at safety and accessibility with setting the targets. Sorry, the Liberia team, I can see your hand is still up. I believe that's an old hand, so do you want to put it down so that I can be sure when your hand is raised again? Over to you, our guest speaker. Thank you so much.
Mr. Mutanara, are you able to come off mute?
Good afternoon.
Good afternoon,
Good
sir.
afternoon.
We can hear you clearly.
Thank you. Thank you very much. My name is Menard Mtenerwa. I am the blood supply executive from the National Blood Service Zimbabwe. And the National Blood Service Zimbabwe is a non-profit making organization. And, its structure is that it is a board of directors, which is composed of 4 committees. And the committees in the remuneration and human resources, audit, risk and compliance, governance, strategy, finance, and then the 4th committee is the technical committee. On staffing, we have a complement of 210, and the service operates in 5 regions. And the regions these are the major cities in the country. And just to mention them, they might not make a lot of sense to you if you don't have the map. I'm sure the map is on the next slide. Let us go to the next slide. Yes, so that's the map of Zimbabwe. We are bordered by Botswana, South Africa, Mozambique, Zambia, and also Malawi. If you look to the north there, there is a center which is in the capital city, that's the Harare, and that is the headquarters. And in that center, we do blood collection, component production, centralized testing, and also distribution of the blood. And then if you look at to the east, that is another city there called Mutare, where we do collections, component preparations, and also distribution. The only thing that is not done there is screening, which is transfusion transmissible infections. And then if you go to the center there, that's the Midlands, where we have a city called Gweru. And also do blood collection, distribution also there. Then we have another center at the bottom there, that is Bulawayo, is the second capital city of Zimbabwe, where collections also are done, component preparation, and also distribution. So those are the 5 regions that I was referring to in the previous slides, where we have the static clinics on each of that collection center. And then from those collection centers, the static clinics, which collects approximately 15% of the annual collections, we have teams that go out almost every working day to reach out to places approximately 200 kilometers at the maximum in radius from each center. And those teams, because they are mobile, we refer to them as mobile teams. They then go and collect blood away from the static clinics. You can move to the next slide. Are you hearing me? Thank you very much.
Yes, we can hear you clearly. Yes, we can.
Okay. Thank you very much. Now, I've just included this as the blood supply chain. In Zimbabwe, our strategy is 100% voluntary non-remunerated blood donation. And we have the recruitment first, is the recruitment arm. In the recruitment arm, it is a function that goes out to inform, educate, and also communicating with the potential blood donors and also regular blood donors. And once they have been convinced that they are going to net, they've been persuaded, we then go and we then collect blood from them. The collections, as I said in the previous slide, we collect at both static clinics as well as out of the static clinics in using mobile drives. And then after collecting the blood, we then do component preparation, separation, and also screening of the blood. And that blood, when if it is reactive or if there is anything that is adverse, we then discard it. And that is clean, then qualifies for distribution. And all this, we ensure that high quality standards are observed. And then we distribute to all the hospitals, which are more than 200 in Zimbabwe. Next slide, please. Well, this diagram is just telling us the overall blood transfusion chain. And in Zimbabwe, when it comes to this strategy, we target the whole population and the general population. But from the general population, we then do targeted messaging. And when we do the targeted messaging, that is how we are going to select the blood donors. But the blood donors, you can have some who fail. That is, if it is on TTIs, on transfusion transmissible infections, they will be infected. But what we then do is that we need to select low-risk donors. And in the blood bank, when we collect blood, then we process it. And then it is the benefit of patients in the hospitals where they receive the recipients of the blood. But what we then educate even the blood donors and also the recipients and the general population is that blood transfusion or transfusion medicine is never 100% safe. There can be some adverse events. But while we are doing all this, there are costs that are involved, and the costs needs to be managed, needs to be to ensure that they are lowered. And everything that we do, we ensure that safety measures are in place to protect the donor and also to protect the recipient, and also the workers that are involved in blood services. Next slide, please. Now, I'm going to speak about the blood donation sites used most often with the highest yield. These are the static and mobile clinics. And what I would like to emphasize on this slide is that the most important people at a collection site are the blood donors themselves. These are our assets. And without them, without their blood, a service cannot continue to operate. We cannot call ourselves a blood service if the donor is not there. And because that is very important, we need to ensure that the conditions that are surrounding the blood donation, that is the environment, should be safe, it should be pleasant, and it should be convenient as far as is possible. We ensure that this is done through our static clinics first. Static clinics, they satisfy all the three conditions that are stated. And then on the mobile team clinics, what we do is that we go to places. If it is public places, there are places that we find a lot of people, and we negotiate with the owners of buildings that will be there, ensure that when we collect, although we have moved or driven to those places, when we get there, we have a clinic, and that will be static for that. It can be a school, it can be a hospital setting, it can be a church, and it can be a council hall. So that is very, very important. And if you do poor service delivery, it will create a bad image for the service, and this can lead to loss of our asset, which is who is the blood donor. And there is also considered that a return donor is the safest, and they demand few resources, and they are also more reliable. So on this one, we are now emphasizing on blood donor retention, that we need to retain the donors. Next slide, please. As far as, well, I heard the presentation from Malawi. We also have a donor enrollment and assessment forms that the donors use. And it is a standardized form. It can be hard copy or electronic. We have moved to electronic completion of or assessment of the donors. And the criteria that we also use is that we need, at the end of the day, after we have answered the questions and everything, you need to satisfy the general qualifications. That is, the age should be 16 to 65 years, and you should be healthy, and you should also be leading a low risk lifestyle. Then you qualify to be a donor. Of course, laboratory tests or screening will also be done to ensure that whatever the donor enrollment and assessment questions and the health questions missed or confirmed, it will also be confirmed by the laboratory tests. Next slide, please. Now, I've just written those 6 terms there. Donor retention is the ability to keep a recruited donor active. And that is one strategy that is very important. We need to keep or to retain or to ensure that the donor continuously and constantly come to donate or gives blood. And then the other strategy, which I said in the diagram in previous slides, is that we do 100% voluntary, non-remunerated blood donation. Of course, it has its challenges, and you find that you need to really give information and educate the population so that they appreciate, they know what this voluntary non-remunerated blood donation is all about. This is one area which can actually drive donors away from you if you don't treat this or package the message properly and convincingly, because you may have then someone asking you that, what am I going to get when I donate? And then they may just say, what are my relatives and friends going to benefit? So we spend a lot of time debating and also trying to ensure that we have the uniform packaging. Okay, thank you. The uniform packaging of the message there. And then you need to recruit. We say that we use the 4R strategy. That is recruit, retain, realign, and regularize. And the realignment is you are sessionalizing the donors. And we do that to ensure that during times of shortages, we have supplies. And then when you are regularizing, someone is now giving you blood constantly. Next slide, please. I've seen that I have 5 minutes to finish this. Then we need to create a sustainable blood donor base. And what we do is that whoever we convince, whoever starts donating, they should be retained and they should donate continuously and constantly. Males after every 3 months and females after every 4 months. Next slide, please. Then what we also need is that they should strive to develop positive community attitudes. I have emphasized this in the previous slide. And then there is also need to build a strong blood donor base. And it requires considerable patience, hard work to produce a stable pool of voluntary non-related blood donors. And that is how you can sustain a blood supply. Next slide, please. Well, we also need to identify the target populations of the blood donors. As I said in the previous diagram, in that you target you go to the whole population, but within the whole population, you then have to segment the populations. In our case, we are segmenting them according to static and mobile clinics. And within the static clinics, we will also say, are you an adult blood donor or are you a youth? And we also have when we do the mobile blood drives, we then say, are we going to visit corporates? Are we going to visit schools? Are we going to visit faith-based organizations? So that is the targeting that we also do. And when we do these visits, we also have champions for blood collections, those who work with us and do a lot of convincing in promoting blood services. Some of them at schools where they are peer promoters, and the peer promoters, they will just be other school children that will be working and promoting blood services. We also have teachers who will be our contact people when we visit the schools. Next slide, please. Then we have this other group, and it is we refer to it as Pledge 25. And this is a group of individuals who pledge to donate or to give blood 25 times after they leave high school. This is a club that was initiated in Zimbabwe in 1994. It gives us 15% of the annual collections in Zimbabwe. Next slide, please. Then what we do, we quantitate or we quantify when we are setting targets. For static clinics, it is 15 blood donations per day. And for the mobile clinics, the target is to collect at least 40 units of whole blood. each time that we go out. Next slide, please. Well, as I said in some previous slides, blood donation and blood services is with costs. And as NBSZ Zimbabwe, we survive on reimbursements. And the funds that we generate, they are generated. Next slide, please. Well, I cannot emphasize this any deeper, that the asset is the blood donor, and everything that we do is that we are promoting blood donation and blood collection, and it has to be safe. And let us continue learning so that we ensure that there is adequate supply of safe blood to all those who need it. Thank you.
Thank you so much. That was really educative and informative. It's so nice to hear how you're doing things a little different from what we had earlier from Malawi. Again, just like we did earlier on, we will take questions and answers. Again, use the raised hand button, or do well to type in your questions in the chat room. I don't know, do we already have questions in the chat room? Let me quickly check that. All right. Again, in Zimbabwe, I would just ask, what percentage of the total blood collection that you have was voluntarily donated? And so when I say voluntarily donated, let's exclude the family and friends donating at the point of need. What do the numbers look like in Zimbabwe?
Thank you very much for that question. In Zimbabwe, we only have one type of donation. It's 100% voluntarily, non-remunerated donations.
That's fantastic to know. Wow. But do you think the blood you have right now, is it able to meet all your needs, or do you still have some shortfalls? And by what percentage are the shortfalls right now currently?
We have shortfalls of close to 30%.
I think that's not bad. That's not bad for a developing country like us. Yeah, I think that's very good and laudable. Thank you so much.
And then our shortfalls also needs to be interpreted in consideration of periods. Is that there are some periods when we are able to meet almost all the demands, but then there will be some periods when we have shortfalls.
Based on your trends, do you have an idea of what periods those are? Is it like a seasonal period? Is it like something happening in the country? Or do you have any trends to what those periods look like when you have the shortfalls?
We get more than 70% of our collections from schools, school-going children. And when the schools are closed, that is when we have major shortfalls.
That's interesting.
And because of that, that is when we'll be focusing and concentrating on adult blood donors. I've spoken of sessionalization and regularizing, and also segmentation. So we do our collections and our drives in such a way that during the periods when schools are open, we focus mainly on schools. But when schools are closed, we then also increase our focus to be on adult blood donors, corporates, faith-based organizations, and the Pledge 25, the youth.
All right, all right. Thank you so much for that. I can see a couple of hands up. I will start with Malvis from Malawi. Do you want to go ahead?
Okay, it's Mrs. Kadonda. Yeah, so I've joined in with Mavis.
All right, thank you.
Yes, so I have a question on he mentioned about PA educators like mobilizing their peers. I want to understand maybe how that goes, how that goes, and how do these peer educators come in when it comes to motivational talks? Do they conduct motivational talks when the blood donation team is coming in, or they are supported by the NBS staff? How do you manage like the motivational talks with the peer educators? What is their actual role?
Thank you very much. I have to introduce you to, I'm not alone in this, in the room where I am. I'm joined with the team leader for blood donor coordination. And what we refer to as blood donor coordination in our setting is those are the individuals who recruit blood donors. And I am going to, his name is Mr. Zephania Chauna Saira. I'm going to invite him to answer the question that you have just asked.
Thank you very much. Good day to everyone. Your question is very prominent, and I really like to help you. What we normally do is our peer promoters every year during the end of the year. The students who are in Form 3 and Form 5 are nominated as prospective peer promoters. Then come January, February next year, we invite all our peer promoters for training at our branches scattered throughout the country. So they will come with their contact teachers as well for training. So we have got a one-day workshop or induction course whereby they go through the process of blood collection, screening, testing, processing, and quality checks. And at the end of the day, we also give them questions, and then they write a short test, a pre-donation and a post test after the induction. What happens when they go to the schools now, because of the Pledge 25 Club Zimbabwe, the Pledge 25 Club Zimbabwe and peer promoters, these are sister clubs. So what we do is when the students are about to graduate from their high schools, they will come up with lists for those graduates who will be inducted into the Pledge 25 Club Zimbabwe. That is why in every town, in every service center in Zimbabwe, we do have currently about 81 collection sites for the Pledge 25 Club Zimbabwe. And in terms of motivation talks, these are done by National Blood Service Zimbabwe. The peer promoters are there to work as ambassadors when we are not in the schools, and also to clear some of the myths that may arise from waste blood taken, and are there any cost at National Blood Service Zimbabwe? Is it used for the ritual purposes? So these are our ambassadors, and the teachers are also going there to help us in their staff rooms to clear some of these issues that teachers have in terms of learning. And when these students graduate from schools and also start their tertiary education, we also use them as peer promoters at tertiary institutions. And also some of them are also used at corporate level. So they were peer promoters at the schools, and when they're going to the corporate, we'll still induct them, and we'll still make use of them as our peer promoters, even at the faith-based organization. These are used to just help us to ensure that they mobilize people at the local level. I'm done.
Thank you so much. It's well understood. You're really using them quite well. We would like to copy from that.
All right. Thank you so much, Malawi team. And the Zimbabwe guests. I'm happy to see that some cross-country learning is already happening Great, great, great. I'll open the floor to the region one from the Liberia team. Do you want to go ahead with your questions?
Yeah, this is Region 1 Liberia, Mobile speaking.
Yes, please go ahead.
From the Zimbabwe map, there were some centers where I saw only block collection and distribution. And then when you look at the far east, there was somewhere where you collect, you test, and distribute. So does that mean that these sites that you have only block collection and distribution don't do testing? For example, in Quick, you see block collection and distribution. If you go to somewhere up close to Mozambique, I see block collection, component production, centralized testing and distribution. So you have several places with only block collection and distribution. Are they not doing testing, and how do they do that? Hello?
Thank you very much. Yes, I've heard your question, and let me just summarize by saying all those senders, they collect blood, and they do blood grouping. Well, on collections, all senders collect blood. Then let's go to donation testing. All the senders do blood grouping, but transfusion transmissible infections is centralized. And also the tube grouping for all the senders is centralized, and that is centralized at the HQ in Harare at the top there, at the north there. Then when it comes to component preparation, all the senders, they do component preparation. And then distribution, all the senders, they distribute that. That's the summary. Hello?
Sorry, I think you should take that again. I'm not sure they're very clear on that. Do you want to take it one more time to be sure everybody understood that?
Okay. Let's just, I'm taking you through the blood transfusion chain. All the senders, the 5 senders, they recruit blood donors. And all the 5 senders have a static clinic and also a mobile, and also they do mobile drives. Then when the blood is collected, each sender keeps its blood, the whole blood unit, and processed. But they also do component preparation, separation of the blood into pegged cells, platelets, and fresh frozen plasma, cryoprecipitates. That each sender does that. But then when it comes to laboratory testing, each sender do blood grouping, but the blood grouping that each sender does is the peck grouping, taking a segment from the blood peck and perform blood grouping. Then there is centralized testing, all the same samples for all the donated blood. They are sent to the HQ, that's Harare, at the top there, the north, where they will all be done blood grouping and transfusion transmissible infection screening. So the transfusion transmissible infection screening and also the blood grouping for the tube group, they are done at one place, which is the HQ. Then distribution, all the senders, because they have blood that they will have collected, prepared separated into its various components. They distribute blood to the clinics and hospitals that surrounds them. I hope this is clear now.
Let me just be sure I got the recap. So I
Yes.
think the most important bit is, so after the collection at the various centers, they do the first grouping and cross matching, and then the grouping again goes to the HQ, which is done there and is screened for all the infections. However, the distribution happens at the various centers. So we're saying the blood doesn't come to the HQ, it's just the testing that happens at the HQ. Am I correct?
You are 100% correct.
Fantastic, fantastic. I think for me, my only question around that is, how do we ensure there are no mix-ups when the samples are taken to the HQ? Because it means they don't get the blood, they just get samples, do the testing, and then send back the results to the centers. How do we ensure there are no there are no any forms of mix up with the information that is being gotten to them and taken back to the centers?
Well, we have
So
the
that's
unique
around
symbol.
quality.
We have unique symbol identification. We use barcoding, and there are entries that are done at collection site into our blood bank management system, and there are checks and controls to ensure that there is no mix-up.
All right, all right. I think that's good to know. So the reason why I asked that question is because we're hoping for the next webinar we'll begin to go into more of quality assurance, ensuring that not just that the blood is available, but also ensuring that the quality of blood available is safe for use by the end users. Thank you so much. Region 1, do you still have any more questions?
Yeah, there's one that I'm seeing there where it's saying how are symbols taken to, okay. There's another one which was saying that hopefully are saying the HQ does forward grouping, then the other does back grouping. No, that's not what I'm saying. I'm saying that the senders, they do pick, well, they test the blood group from the pack or from the blood pack. And then the HQ receives samples, say for blood grouping, there will be EDTA, and the blood grouping is for both these senders and also the HQ. It will be a full blood group where we do reverse and forward typing. And the only difference is where the sample for blood grouping is coming. One is coming from the blood pack, and also the other one is coming from the tubes that we have been collected simultaneously when the blood is donated.
Thank you so much. There's another question.
What is
around
turnaround time? Okay.
Yeah, that's the question. Yeah. How are the samples taken
Turnaround
and the
time,
turnaround time? Yes.
72 hours at
Oh,
most.
fantastic. Fantastic. I think that's good enough. Thank you so much. I know someone is representing the Liberia team. Just to make sure you're not left out of the conversation. Do you have any question? Or is there anything new you're learning from the conversations?
Okay, I'm done with my question. I think it's clear when he explained it.
Oh, thank you so much, Region 1. I was wondering, the person representing the Liberia team, do you have any question? Do you have any contribution? Do you want to say one or two things about what's happening in Rwanda? Just 2 minutes if you want to, but it's fine. We can move on.
I'm gonna put my hand up. With my hand on there. Hello?
Yes, please go ahead.
Okay, this is Liberia and this is mobile.
All right.
During our production of our policies and strategies, we were also talking about satellite production centers or collection centers, which resembles what I see on the Zimbabwean map. So that's the reason why I asked the question, because there were a lot of argument about what to be done. And based on the explanation I got from the Zimbabwean, who is the guy there? The Zimbabwean guy did explain what we were arguing about. So I think if we get back to our own satellite map we had in Liberia, we can now understand some of those arguments that we are making. For example, we have places where we do collect, but we don't test. And then we send it to other places where they have to test and distribute. So at least that's the reason why I asked that question, so that it can be clear to me and other people who were in that meeting when the argument was going on, so that they can also understand that these things can happen. So it's very good that you explained it clearly. I say thank you to him.
Thank you so much. Wow. I can see that there are lots of other comments coming in. But time is already spent. I'm trying to read what's in the comment section. Um, this should have ended about 15 minutes ago. So please keep bringing in the questions. We'll send them to the guest speaker to respond, and we'll provide the feedback back to everyone. One of the other things we're hoping to do during this session was to have a breakout session where the teams will be able to think deep on what they've learned today from Malawi team and also from the Zimbabwe team, and see what we'll be doing differently. But from our questions and answers so far, it's obvious that we've learned one or two things, and we've also said one or two things that will be taken home and be changing to ensure we have better access to safe blood in each of the countries. So I think my humble ask from the three countries that are on this webinar today is, please can you kindly go back and come up with a country specific plan. So, what innovative ideas are you going to take away from this session and they're going to be integrating into your system? Nothing big, but something that you can say, oh, based because I attended this webinar, these are the key things I'm taking away, and we will be going back. So, when I say we, I mean the old team will be going back to implement and to see how we can change the situation. From all the questions, it's obvious that we've learned one or two things. The Liberia team just spoke about the similarities between what they have in Zimbabwe and what they have and how they can improve on their own. Earlier on, someone from Malawi had made mention of something they hope to incorporate. So I will be really nice for this to be documented and shared with us. And something I've learned is best to do what you have to do immediately. Procrastinating will result in you not getting anything done. So we really appreciate if you can send this back to us, let's say Monday. I hope that's good time. Again, I would love to hear responses from everyone. Is Monday a good time for us to send in back what we will be incorporating in our system based on what we've learned today? What innovative things will we be doing based on what we've learned today? Is Monday a good time? Yes, we will share all the slides with everyone on this call after now. Does Monday sound good? Please unmute yourself, just say yes, or put in the chat box yes. Does Monday sound good? All right. Thank you so much for the encouragement. So by Monday we'll hope to hear back from the 3 countries represented here. So we'll bring the webinar to a close right now. The conversation continues. We hope to have another webinar a month from now. And like I said earlier on, it's just to ensure we have safe blood available. So a lot of the next conversation will be around immovigilance and quality control before the in-person session that will be happening next year, hopefully January at the latest, February that will be happening next year. Thank you so much for your time. Thank you so much for your time, and we really do appreciate your joining in, and I hope it has been a good use of your almost 2 hours. Thank you so much again, and do enjoy the rest of your day. Bye. Sorry, Rijawan, do you have a question? I can see your hand is up, or is this an old hand?
Yeah, you did ask for Monday schedule whether it will be okay for also meet again.
Yes, please. Is Monday fine? No, not to me. Just send in the innovative thing you'll be doing within your team based on your learnings from this webinar.
Oh, okay.
Yeah. No, we're not meeting. But we'll be having another webinar a month from now. So that will be first week in December. We'll be having another webinar then. All right.
Before you leave, you can turn on your camera so we can take a group picture.
Thank you so much, Julie, for that.
Yeah, so if you want to just turn on your camera real quick, we'll just take a picture. I understand that many of our networks don't always help with that, but it'd be great if we could get everybody's face. Wonderful. Wonderful. Stay there, stay there. All right, thank you so much. Really appreciate you being able to join. All right, thank you. Have a wonderful rest of your day, and we look forward to seeing you again in the next month. Apologies, I'm in the US and it's just before school, so this is my son learning all about blood donor recruitment, mobilization, and retention. So start them young.
You're raising a blood donor expert.
Thank you all. Have a wonderful rest of your week.
Thank you.
Bye.
Thank you.
Bye.
Thank you.
Bye, everyone.
Bye.
Bye.